So good morning, colleagues. Thank you very much for joining us. My name is Linda Ball. I'm a Professor of Public Health in the Usher Institute at the University of Edinburgh. And I'd just like to welcome you all to the 12th in the series of our COVID-19 webinars. Many of you, I'm sure, joining by Zoom today have joined these webinars in the past, so you will know how it works. We're live streaming on YouTube. Do draw the attention of your colleagues to that link afterwards if they'd like to listen to the webinar subsequently. I'm just going to say a few words about how these run, if there's anyone joining us now who's not used the system before. So we won't be able to see you, but you can, of course, pose questions throughout the webinar, and please do that in the Q&A box at the bottom of the screen rather than the chat function. Then I'll be able to see your questions. If you spot somebody else's question that you are particularly interested, do click on the thumbs up sign. That helps me see which ones are most important to ask of our speaker. And then after the webinar, I will just say a few words about the subsequent webinars we have going up to the 3rd of July. But I'd like to thank the Usher comms team and also Professor Aziz Sheikh, our director, who set up this series. So I'm going to introduce our speaker now. I'm particularly delighted actually today to be able to welcome Professor Michael Baker. Many of you will have been following with interest what has happened in New Zealand, which in many ways is unique in its approach to addressing the pandemic, and I'm sure there's a lot we can learn. Michael is Professor of Public Health at the University of Otago in Wellington in New Zealand. He has a wide range of public health interests, a particular focus on environmental health, infectious diseases and housing. And he's been very prominent in the field, but more importantly, at the current time, he's a member of the Government of New Zealand COVID Technical Advisory Group for the Ministry of Health in New Zealand. So I will just check if we're okay just for a second. Laura, are we all right to start? Yeah, great. So I'll hand over to you, Michael, if you're happy to share your screen. And thanks very much again.
Yeah, kia ora from New Zealand. It's a great pleasure to join you this morning in Edinburgh, and of course this evening in New Zealand. I'll just bring up my slides. And I was just talking with Linda beforehand, and I think all of us in New Zealand share a huge affinity with Scotland, and I think many of us have, most of my ancestors are from Scotland, and I think we share a very similar, very pragmatic and humanist approach to dealing with public health issues. So I'm really delighted to join you tonight to share some of the experiences from New Zealand, and particularly our elimination strategy for COVID-19. And I think at this stage we have achieved success at this point, but certainly uncertainties and risk remains, and that's really some of the points I want to discuss tonight. And some of the, I've listed some of the other contributors to this presentation here. So although we're at the University of Otago, which is down in Dunedin, in the southernmost, one of the southernmost cities in New Zealand, I'm at the clinical school in Wellington, which is, as you know, is the capital. And so today I want to talk about a few of the lessons we've learned from our experience over the last 3 months. And I think everywhere in the world, anyone working in public health has been astounded by some of the events that have unfolded. And also I think the huge global effort to combat this really unexpected threat. I'm going to talk a bit about some of the strategic choices that countries face, this continuum from control through to eradication, some of the components in an elimination strategy around exclusion, reducing transmission, and case management, which is often a lot about testing and contact tracing. Some of the features of the lockdown in New Zealand, what else we need to do going ahead, some of the uncertainties, and hopefully some of the implications and the generalizability of the experience in New Zealand that may be relevant elsewhere. So as we know, when you're confronted by a threat like a new pandemic, there are a whole lot of factors that you think about in terms of how you're going to respond. I mean, we often think about the health impact of a pandemic, particularly case fatality risk, and ideally the infection fatality risk, which is usually unknown at the beginning, the transmissibility of a new infectious agent, and its controllability. Do we have tools that can actually limit its spread or mitigate its harm? A huge driver in New Zealand, as I think in many public health settings, is the question of inequalities. Infectious disease and pandemics always magnify patterns of inequality. There's questions always about the certainty of information, the science capacity to actually even change your direction, particularly in small resource-poor countries. And there's always I guess this, whether it's a strength or it's a reality, we don't know all the options. There's often uncertainty about the counterfactuals. What are you comparing your particular assumptions with? How much experience do you have? And really no one alive today has, certainly in Western countries, has experienced anything like this. And we're very familiar with the fact that SARS, countries that experienced SARS, have learnt a different approach, which I think I'll come back to. And often we're up against dogma that we do tend to recycle some of our strategies from previous events, previous pandemics in particular. Just to briefly mention the question of inequalities, and particularly ethnic inequalities, are a huge concern in New Zealand. And this is looking at 3 influenza pandemics, and the fact that the mortality rates are always patterned by ethnicity in New Zealand. And so going into a pandemic now, it's been a huge concern in New Zealand not to repeat these inequalities of the past. So when confronted with this pandemic, the approach was to roll out the familiar pandemic influenza plan. And virtually every country on earth has one of these, and that's with good reason, because as we know, influenza pandemics tend to recur about 3 times a century. And that's certainly the pandemic event that all countries would have been preparing for. And the World Health Organization has promoted a certain model for these for at least 2 decades. And so we had our trusty pandemic influenza plan. It's essentially a mitigation approach. The assumption is you cannot contain influenza, and therefore there's a big focus on keeping it out, stamp it out, manage it, and then after the peak, there's you coming down the other side. And these pandemics are relatively short-lived. They may move through a population in a couple of months. And so this was the model that New Zealand was right up till really early March was busy implementing. And at that stage, we'd had about 100 cases of COVID-19 at that point. So if we go back to fundamentals, for several decades, there's been this basic model that you can have control approaches, reducing incidence to acceptable levels. Elimination is something that is now has been rolled out very successfully for a number of diseases, and we're all very familiar with the approach, say, to polio and now measles and rubella. And one of the jobs I do with the World Health Organization is I'm on the Regional Verification Commission for Rubella and Measles Elimination in the Western Pacific region. So we look at plans from countries in the region once a year and say, yes, they've achieved elimination status or they haven't, and that's based on certain criteria. And the ultimate goal, of course, is eradication, the global absence of infection, and that is unfortunately only been achieved for smallpox so far, but there is a number of other diseases that are on the list. That's for human diseases or veterinary diseases, which have also been eradicated. So we, during the early March, myself and a number of colleagues decided, in fact, that mitigation really wasn't the right model, And we decided that elimination looked like a much better approach with COVID-19. And that was really drawing on the experience of Asian countries, particularly China, which had stopped a pandemic in full flight. And we were very impressed with the report of the joint mission to China that the World Health Organization published on its website at the end of February. And also, we're looking at countries like Taiwan, which had, I think, arguably the most sophisticated response to this threat. And they'd basically were taking an elimination approach. So we started to think, well, what would elimination look like? And this would be the absence of detected cases for a defined period. Maybe we calculated around 28 days would give a high likelihood of having eliminated this disease, the presence of high-performing surveillance system, and you'd have to have some exclusions, such as cases that were identified at the borders and were isolated or quarantined. So we thought elimination did look like a good strategy. And one of the differences, this is, sorry, a very busy slide, but you can think of all the components of a pandemic control system: managing borders, case contact outbreak management, surveillance, physical distancing, communication, all these other things that you have to do. And the fact that many of them are exactly the same for the standard influenza mitigation approach as you might take for an elimination approach. But the differences really come down to just the timing and intensity of approaches. And obviously, if you want to eliminate, you have to manage your borders very intensely, far more intensely than you would for mitigation. You would need to put a lot more effort into identifying cases and their contacts, and contact tracing and quarantining, and also more surveillance to detect cases. And you might need to consider public physical distancing and movement restrictions, potentially at the level of a lockdown. I've always been a bit uncomfortable with the term lockdown, but it seems to be fairly entrenched in discussions now. And in addition, and I think I haven't highlighted on this slide, but I think mask wearing is really emerging as a very useful technology that may reduce the need for physical distancing. But the big difference is the timing of these approaches, because in a mitigation approach for influenza, you gradually increase the intensity of your response as the pandemic gets worse. But with an elimination approach, you do the opposite. You actually put maximum effort in at the beginning to try and eliminate chains of transmission. So that I found myself in the position in early March in New Zealand, or moving to mid-March, of arguing for a very different approach, and that was to this very intense lockdown at the beginning. And there was not agreement at that point that was actually the right way to go. And some of my colleagues said, you cannot eliminate this virus. So this is looking more schematically at I think the strategic choices for countries. And this is something we put together in really early April, when we started to look at what was happening globally. So New Zealand shifted from what you'd say was a mitigation approach to this elimination strategy. And that was really trying to eliminate chains of transmission. And the hope is that if you can do that, your exit path is to return to this new normal, another annoying cliche now, that term. But that would result, if you acted quickly, you'd have fewer cases, fewer fatalities, and your economy, although it would be damaged by the strategy, the intervention, the hope is you could return to normal functioning sooner. Several countries were heading down really the mitigation strategy, and in some instances they talked about, as we know, herd immunity, which, and I think this was quickly abandoned by most countries, except possibly Sweden. And in fact, most countries wound up in a suppression strategy. And of course, some low-income countries really had no substantive strategy at all. but these all result in different exit paths here. Again, this slide, I'm not expecting to take you through this, but this is the Ministry of Health's recent summary of the pandemic curve and all of the timing of a whole series of events and interventions. And particularly, you can see here these changes in the alert levels, which I'll come on to, and really level 3, level 4, about 7 weeks here, is a fairly intense, or initially very intense, lockdown at alert level 4. So if you think about an elimination strategy, it's got these elements, and most of them, again, will be very familiar. The idea of excluding cases, this border management, and as I showed you on an earlier slide, a lot of Pacific islands and probably islands in the Caribbean and other places did this. They basically lifted the drawbridge, so they basically entirely excluded cases. But certainly this is obviously a critical part of elimination, and that's the ability to manage your borders. You don't have to be an island to do this. Places like Vietnam have succeeded very well by just managing their land borders. Then you need to do things to reduce transmission, and that's transmission per contact and also the number of contacts. And then you need this ability for case and outbreak management. So if we think about that a bit more, you've got these key components here at the border. Entry restrictions, and in the case of New Zealand, it was near border closure. We had one amazing day when no one arrived or left New Zealand, and people had to look back for decades to see when that had last occurred. Initially, we had a process of self-isolation for 14 days, and then more recently it moved to supervised isolation and managed quarantine. So there was a lot more scrutiny, and partly because the numbers have become very small. And also you have to think about managing air crews and seaports. So these key dates here where these measures were gradually implemented. And I don't know if any of you have been near an airport recently, but they are very different environments from how they were prior to the pandemic. And so that was borders. So the second area is around reducing transmission. And we're all very familiar. I mean, I'm really amazed now that just about everyone in New Zealand, all the public seem to be epidemiologists now, and they're all comparing notes about what is the current R value in the reproduction number, effective reproduction number at present. And of course, this number, of course, has these three contributing parts: how much transmission, contact rate, and the duration of infectivity. And unfortunately, we can't modify one of the three components here, the duration of infectivity. If we had antivirals, they would obviously be very useful for this. So we've really got pretty blunt instruments for modifying these things. So transmissibility, we can talk about physical distancing, cough etiquette, hand hygiene, and so on. But masks really in New Zealand haven't had much attention, and that we think was a serious mistake. So there's also a lot of focus on reducing contact rates, the average number of contacts per unit time. And again, you've got limited, you could almost say quite medieval approaches for limiting contacts. So the broad framing, and I'm sorry this would be a bit hard to read, but this was the alert system that was introduced, and I think this turned out to be a really brilliant communication tool, although it doesn't look that brilliant when it's got this, it looks a bit unreadable here, but it was actually communicated much in bite-sized pieces. But the idea was that there was a risk assessment based on how much transmission and a range of measures. And then there was a very effective social marketing program in New Zealand to explain to the public what these things meant. And basically, lockdown at level 4 was essentially stay at home unless you're an essential worker, or you can go to the nearest outlets for food and medical care if you need it, but otherwise stay at home. Of course, you're encouraged to exercise and walk around your block and so on, but this was very intense. And even level 3 was similar. It just allowed you to have a slightly bigger, we talked about bubbles, and your bubbles in level 4 were just your immediate family. You could expand it slightly in level 3. And level 2 was a much more open, and we're now at level 1, which is essentially only has restriction on borders. So the physical distancing, all of the usual elements were in here: closure of schools and workplaces and public transport, stay at home at level 4, physical distancing, limited travel. But we didn't use face masking or mass masking, which is wearing mainly reusable fabric face masks by the public, was not an established hygiene activity in New Zealand. And these were showing some key dates. We moved rapidly into level 4. And as I was commenting before, this was the fundamental point at which New Zealand committed to elimination strategy when on the 23rd of March, the Prime Minister came out and said to the entire country, we're going to have 3 days at level 3, but we're going immediately to level 4. And that was a day when it was very clear we were adopting an elimination approach for this virus in New Zealand, rather than ramping up these controls in the normal sequence. And there's many images of social, I should say, we've changed the language to physical distancing, I think, like many countries. So the kind of, this is the physical distancing to reduce transmission per contact, physical distancing. And as I was saying, stay at home if sick, hand washing, cough etiquette, infection control in healthcare settings, excuse me, but not this use of mass masking. So the third component, after border controls, reducing transmission, is case and contact management. And one of the reasons we advocated strongly for going into an intense lockdown was that our public health infrastructure was very poor at that point. We had very little testing capacity, and contact tracing was really very poorly developed. So one of the reasons we use this time to greatly increase testing capacity, contact tracing, and also, of course, the intense lockdown, its main effect was also to extinguish many chains of transmission. And I think the third reason was that it also was a way of explaining to people what physical distancing meant, which people are not familiar with in New Zealand. So testing was not established till early February, and it took a while to get up to a reasonable capacity, and also to get a national close contact service created. And there was, in the end, we had high volumes of testing being done all around the country. And of course, one of the effects of the lockdown was that virtually every other respiratory disease stopped. And influenza over this period dropped to a 40th of its normal, its pre-lockdown rate. Basically, almost all infectious diseases transmitted between people largely disappeared. I mean, interestingly, one disease increased, and that's rheumatic fever, and that's because the infectious agent, group A strep, is carried by people, and so crowding is a big risk factor, and so actually the rates of that disease actually went up. So this is looking at the epidemic curve, distinguishing cases according to whether they're imported or import rated or locally acquired. And what we started to see was this changeover from imported cases to increasingly locally acquired cases. And I think the timing meant that we were just at that stage where the pandemic was switching to being excuse me, predominantly imported to becoming community transmission. There's just some very basic slides here to show some of the epidemiological characteristics. I feel obliged to say place, person, time characteristics, but a lot of this just reflects where people had travelled from and where they returned to when they got back to New Zealand. There's nothing very special about the geographic distribution, and again, the age distribution doesn't tell us very much, because this in many ways was just the distribution of travellers, and there's quite a strong healthy traveller effect, which meant that we had in the end a low mortality risk in New Zealand. And then again, just looking at the by the end of the pandemic in New Zealand, the distribution of imported cases and locally acquired cases. And this pattern would have changed very dramatically if the pandemic had become very established in New Zealand. So this is work done by my colleague Sean Hendy and his group, and this is using a SEIR model to look at the effective reproduction number at different stages of lockdown. And this is at level 4. We went from, I should say, this is the prior to lockdown, the effective reproduction number of almost 2 during this period dropped to a very low level, 0.35 during this period. And it was assumed to have increased under level 3 and then under level 2 here. So this, of course, had a very dramatic effect in extinguishing many chains of transmission. And this is another colleague, Alexei Drummond, and his group using phylogenetic methods to look at the impact of the lockdown on the reproduction number, the effective reproduction number. And this again is during the lockdown, or also prior to the lockdown, and then after the lockdown was implemented. And again, showing very, fortunately, very similar results to the disease modelling, that there was a very marked reduction in the effective reproduction number. And here they've actually been doing similar work in Australia and Iceland, and again, seeing very similar results in terms of the ability of a lockdown to really suppress transmission of this virus. So this plan was delivered to all New Zealanders in March, and that had details about the alert levels. And what, in terms of going ahead for New Zealand, we're thinking obviously about the kind of pandemic, ongoing pandemic threats the country faces. Obviously, border management is going to remain, was now key, since we are very confident we've eliminated the virus in New Zealand. We're obviously about to go through winter, where coronaviruses become more transmissible. And we, at level 1, a lot of us feel a bit squeamish almost that we're now going back to allowing the kind of events where, which are notorious for transmission of this virus, large indoor social gatherings where people know each other very well, they've had a few drinks, and they start to share their respiratory droplets. So this is obviously a higher risk period for New Zealand. We're also very conscious of the effects of the pandemic response and economic hardship for many New Zealanders. We're concerned about increasing inequalities. And I think looking more widely, just multiple global health threats, which do, of course, affect New Zealand indirectly. So actions to maintain elimination status, continuing to careful border management, and this is going to become more challenging because the numbers of people, I mean, there are literally tens of thousands of people waiting to be allowed back into New Zealand, and that would be even just through normal quarantine. We do not have the facilities for those numbers. There's also the other form of pressure, which is for quarantine-free entry, and that has potential to be negotiated with other countries that have achieved elimination. And there's huge pressure for travel from Australia. Australia had a less intense lockdown, and it still has some ongoing transmission at low levels in some states of Australia. So this is the business community, and some politicians are pushing very hard for that. Another action we think could be looked at is establishing a culture of face mask use. And we think actually this is going to be very difficult, excuse me, at this point, because people feel there's very little threat from this virus in New Zealand. We've advocated for it as part of the transport system, international air travel, and on public transport in New Zealand. And we're interested that countries like Taiwan, which have completely eliminated COVID-19, have recently passed a law requiring face masks, mandatory face masks on all public transport. And I think there's similar policies in South Korea and Hong Kong. We have contact tracing, but it needs to be very fast and very complete with this virus. We think there are some good digital tools, probably not apps. They've got real, even Bluetooth-enabled apps are not likely to be very effective. And we think a Bluetooth-enabled card or device that could be issued to all people in the country has a lot more technical benefits, but it does need to be tested further. We're also advocating in New Zealand for a very rapid review of our response, and we think we do need a dedicated national public health agency, and certainly a major inquiry at the end of the pandemic. There's obviously a lot of uncertainties and research questions. What kind of measures will contribute to global pandemic control, vaccines or antivirals? Huge questions about the duration of immunity, whether immunity will be very high in older populations, which are obviously the groups who most need protecting from this virus. If we get outbreaks, I think there's now quite a lot of evidence saying that we may be able to avoid going into lockdowns and instead use face masks and very rapid contact tracing, which will be much more efficient. And as I say, we've been working hard to look at alternative ways of managing the risk of quarantine. And in the modelling we've done, face masks can be a very good substitute, but there would be questions of managing adherence with them. So when we look at the strengths and weaknesses of the New Zealand response, I do think, and this is not just in New Zealand, I think everywhere, if you have good science and good leadership and take decisive action, that does seem to have been very effective in many countries. A thing we found in New Zealand, that having chief science advisors in the Ministry of Health and also the Prime Minister's Department made the politicians more accessible or improved access to decision makers. They were a very good short circuit device when you just felt you couldn't get anywhere. And we did have a period when we felt we couldn't get anywhere with the established agencies. And I would say this is a time, suddenly everyone, you don't have to tell people what an epidemiologist is anymore. And I do think we've had really great access to, at key times, to decision makers. And in New Zealand, high public trust and engagement, and of course the Jacinda Ardern effect has been a real plus for risk communication in New Zealand. Some of the weaknesses have been exposed, have been eroded, fragmented and underfunded public health infrastructure, and sometimes real resistance to change in the face of very good evidence. And I have found infection control practitioners believe they know everything there is to know about the use of face masks, and their paradigm is PPE for protecting healthcare workers, which is very different from a public health paradigm, which is about just reducing the reproduction number. It's a population strategy. It's so different. And that became almost insurmountable in New Zealand really until the WHO changed its viewpoint. And even then, that didn't really change very much. So I don't regard this is not particularly up-to-date or complete.
Oh, I think we just temporarily lost you, Michael, but you're back now. Go ahead, sir.
Did very much differ there? Did you lose very much?
No, you were just introducing this slide, but I can hear you again now. Thank you.
Great, thank you. This is just examples of, I think the exact numbers don't matter very much, but I think the principle is that, and I'm always very wary of doing country comparisons. I think they just need to be put in very broad categories. But broadly speaking, countries that have assumed elimination and containment have a very low mortality rate compared with countries that didn't. And this is not a complete list by any means, but certainly some countries have done, I mean, in the OECD.
Sorry, colleagues, we do seem to be having some internet problems here. Just see if Michael comes back. Just give us a second.
Sorry, Linda.
No problem. I think it's just probably evening and internet, but do continue.
Yes.
Thanks.
Oh yeah, sorry. I'm just almost at the end now. So just pointing out that elimination and containment seem to work well, and other countries that I think adopted really the suppression approach have done not so well. And I think if you look at
Oh dear, we're almost at the end and the internet's failed us. Okay. Do bear with us, colleagues, because you've got lots of excellent questions you posed. Thank you so much for those. I'm sure Michael will be back. So while we're waiting for him to return, if there's any questions you see you particularly want answered, I notice you've been doing that, do flag them. Oh. Yeah, we seem to have just had a hiccup at the end. Maybe if we just speed up to the end, Michael, we can maybe focus on the questions. Really sorry about that.
Right, so hopefully we're just coming to the end there, and these are just some of the key points I think would.
Oh, we've just lost your sound.
Can you hear me now?
Yeah, you're back, yeah. It's just coming and going, yeah.
Yeah, no, sorry about that. So just to finish up, these are some of the key points from our experience in New Zealand about the benefits of
Yeah, we've lost your sound again, Michael, but we can all read what the what's on the slide. Sorry about the sound.
major global health threats, the idea that actually listening to scientists who are concerned about these threats and actually making areas like preparedness, prevention, protection, central themes in our health agencies. We're certainly hoping to use this example in New Zealand more widely. So thanks very much.
Thank you very much, Michael. That was excellent. And those technical problems were very minor. So that's super. Right, we've got loads of questions. There's no way we're going to get through them all. So I'll just ask you the key ones, and we can always email you if there are other urgent things people would like answered. So I guess we've got a lot of interest in your border controls. So Kareem McLeod has asked a question about the intensity of the border management. Were people detained? Were there fines, for example? Did you have any temperature checks? And tell us a little more about the self-isolation strategy.
Yeah, well, early on, people were just told to go and basically they were given information about traveling safely and told to go home and stay there for 14 days. And there's a thing called Healthline, which is where you ring up if you've got health queries. And the people were registered with Healthline, and they were run, not very much initially, and later on they were run more often, but it very much relied on an honesty approach. And it was only after quite late, I think late March, when we implemented a more supervised approach. And that was because the numbers of travellers dropped right off, because essentially the only people allowed into the country were citizens and residents returning home. And I think it's very hard. I think there might have even been an idea that we might even exclude them, but actually, I think it's a major international legal issue if you don't accept your own citizens. So I think in numbers actually started to contribute to the fact that it was possible to directly supervise people in quarantine facilities.
We heard that from Vietnam as well. I think that's absolutely the way that we have to proceed. So I guess the big question, which you will have been anticipating. So Anthony Shooter has asked what all of us are wondering. So there are many similarities, as you highlighted at the beginning, between New Zealand, Scotland, and the UK, but the outcomes are drastically different. So if you'd been in charge of the response in the UK, what would you have done differently from the beginning? I think I know what you're going to say, but also what do you think we should be doing now?
Yeah, well, I was very much just in the standard mitigation camp until, early March, and I just thought there must be a better way. And as part of the images streaming in from northern Italy, I think that also helped our politicians say, actually, that we wanted to do everything we can to avoid that. But yeah, I think any country could pursue an elimination approach. After all, you have all the capabilities. In the UK, you can manage borders. You're familiar with what's involved in various levels of lockdown. You're doing testing and contact tracing, so you have all the capacities. It's just putting it all together and actually committing, saying, actually, we're going to do elimination rather than suppression. I think that's the main thing. The only thing I do differently in New Zealand, I think we have had mass masking introduced right from the beginning, and then we might have been able to avoid the same intensity of lockdown. And it might have even been reasonable to say, look, let's have a less intense lockdown plus masks, for instance. I don't know why. I don't know why that's not on your menu of options, or is it now? I don't know.
Certainly growing. I mean, as I was mentioning when we were chatting beforehand, masks are mandatory now in England on public transport, and I think that the evidence is building all the time. In the paper you were mentioning that you've been working on, looking at the modelling around masks, if the border controls are released, I think will be helpful. So, like you, we've had powerful voices opposed to mask wearing. So we just need to resolve that, I think, because it clearly has got to be part of the strategy going forward. So just some more questions. What about nursing homes and people living in the care sector? Because clearly that's been a huge issue for many countries.
Yeah, and that's been, we've had tragedies in New Zealand because obviously this virus in that environment is very hard to manage. It's not an area that I have looked at very much myself, but it's clearly needs to be very carefully looked after. I was really interested. I mean, in New Zealand, there was a strong voice for saying, let's follow Sweden on the, the mitigation path. And the only part of that sounded sensible to me was you put huge effort into protecting vulnerable groups. And when we were expecting the virus, in February, we were planning on the virus, essentially a pandemic wave coming through the country. A lot of us were very concerned to think about how do you protect vulnerable groups. But fortunately, it didn't turn out to be a major problem here.
Yeah, I think because you kept your numbers so low, you avoided the impact on that sector that we've seen, which is a real win for everybody. So political leadership obviously has been hugely important in New Zealand. We've all watched and been very impressed. So was there real unity on that? Are we maybe not seeing some of the dissenting voices? Was there any resistance to the Prime Minister and the Minister of Health's approach? Yeah, so that's the question.
No, also, we have a coalition government in New Zealand, a minority government, in fact, for Labour, but they have obviously a majority in coalition with two other parties. So that immediately created the potential for division. But I think in the end, with this kind of threat, the politicians all got behind it, and there was very little dissent, in fact, which was a relief. But I thought it was fascinating, the dynamics of who was advocating for this. I think some epidemiologists, including myself, are advocating very strongly for this change in direction, but also our business leaders, and they're quite globally connected. And they said, basically, it was this lifeboat, New Zealand, we cannot go down that path. And some of them had business interests all around the world and were looking at what was happening. And so they were very outspoken. And actually, officials were slower because they tend to want to stick to their plan and roll it out. So I thought that was interesting. Also, at a certain point, the traditional advisory systems completely broke down because they were just too slow. And in the end, I think most of the communication became, it switched over more to being science blogs, which were written very swiftly, and in the end, phone conversations. And the fact New Zealand's a small society, probably like Scotland, and everyone, most of us in Wellington, we know politicians, we can ring them up. And so that was how decisions were being made very swiftly, and we went from we're doing mitigation to we're going to lock down the country and we're doing elimination in one day. It was this incredible speed with which the whole system changed and then had a very smooth implementation on this new direction.
No, that's really positive. Very interesting about the business leaders, actually. So there's obviously, it's a very diverse population in New Zealand, but you do have huge inequalities, particularly in relation to your Maori population. So were they harder hit, or is it more that they're going to be harder hit by the economic consequences? Yeah,
well, they would have been. Maori, and particularly Pacific migrant families living in parts of South Auckland, live in conditions of high levels of crowding and also high levels of comorbidity. So I think this would have been devastating. And we're seeing that with Pacific populations in California, for instance. So that we were bracing ourselves for that. And unfortunately, it didn't happen. And so there wasn't really very much ethnic difference because we had so few cases, and they're mainly, and many of them were in relatively healthy young travelers, in fact. So that was good news, but certainly the response, the unemployment will be higher in less skilled workforce groups, and certainly for Maori and Pacifica. So that's a problem.
And in terms of testing, so your testing strategy, you showed an image of that, and you obviously were able to ramp it up to the level that was needed quite quickly. So was that just symptomatic cases, or were you doing any asymptomatic testing, or is asymptomatic testing just part of research?
Well, initially the focus was on symptomatic, and then once the capacity got up to a very high level, 5,000 plus tests a day, there weren't enough symptomatic people. And so obviously you want to start shifting the focus to key asymptomatic groups who may be highly exposed, because you're starting to find very few positives. And so the focus shifted to people like airport personnel And then there was this quite long period when I think there was almost, the virus sometimes has almost these magical qualities, the idea it might just somehow be out there and you just can't find it, so you have to go looking for it. So there were a whole lot of targeted surveys of people, say in the service sector, police, obviously healthcare workers, saying, well, let's test these groups, and also workers in aged care facilities, to see if there's a lot of virus that we're missing, and there wasn't any. So, and that's still part of the program, was now shifted really to airports, points of entry, with asymptomatic testing.
So you didn't really have a problem in hospitals then either, you know, in terms of transmission within hospitals?
No, basically the hospitals were empty because all the elective procedures had been stopped, and the intensive care units were bracing for this onslaught, and nothing happened. So that was they said it was quite unreal working in the hospitals at that point, because they were not quite a ghost town, but they really were very quiet.
Yeah, that's interesting, because of course now sorry, I'm asking my own question here. A big issue for us is this huge backlog of other cases, cancer screening, surgery. I mean, it's going to be very difficult for us to deal with. But presumably you had a temporary pause, so there will still be some backlog for you.
There's a huge backlog, and I think a lot of primary care procedures, screening for particularly NCDs, I think is, that's going to be actually a big health consequence. There's a huge debate. I mean, this will only be known, I guess, in hindsight, when you add up there's obviously a great reduction in road crashes and certain other negative health consequences. So I don't know what the net calculus will be down in years ahead when we look back on this period.
Yeah. I'm just looking, because there's a bit of overlap with these questions. The social marketing campaign, obviously very interesting. Looks like we all have had a leaflet through the door as well, but presumably there were other, I'm not suggesting you were heavily involved in that, but what were the key components of the social marketing campaign? Obviously quite effective.
Well, one of the things became, particularly when people were in lockdown, the daily briefing with the Prime Minister and the Director of Public Health, or actually the Director General, and it was this wonderful Standup Joe who would give the daily count, and it became the most watched thing on television for a number of weeks. And that also was an opportunity to convey a lot of other key messages. And I think the advertising on television and through social media was exceptionally good. And I don't know which agencies were involved, but they did a wonderful job. And I think it really focused on pulling the whole country together in this unified fight against the virus.
Yeah, that's really interesting. And I know you had a prominent comedian as well, didn't you? Portraying your Prime Minister the same way we've had a popular one here. That's good. It's an opportunity to convey other advice, as you say. Really interesting question here from Genevieve Fernandez, who's saying, how much autonomy was given to local councils or local boards in terms of decision-making for various measures based on local needs, testing, etc., social distancing, as well as data? If you could tell us something about that.
Yeah, well, we have district health boards in New Zealand, which there's 20 of them, and we have a dozen public health units. They had some autonomy, but I think in a crisis, I think things got more, if anything, there was a desire to try and standardize things across the country a lot more than usual, partly because, and this showed the weaknesses, I think, of a lot of infrastructure, that different places had their own contact tracing systems that were not necessarily very compatible. And so I think, rightly or wrongly, there was a lot of centralization. There's also a lot of invested in doing things very rapidly. And, in hindsight, you might have done things differently or a bit better if you'd done it in a more orderly way. So this is a problem if you wound down your infrastructure, you just can't suddenly recreate it, particularly information systems, which take years to refine usually.
We've got a couple of questions here on the technology-based contact tracing. I know you're doing very effective traditional contact tracing. So you said about the digital tracing cards. So Mary Rich is asking, how would they be different from apps? There's another question here. Yeah, just tell us a little bit more about how that might work.
Well, I think this is interesting, and I have been doing our group's been doing a bit of work with one developer who's working on the thing they call the COVID card in New Zealand, but also Singapore is doing the same thing. And even though they were a leader in their app, which was Bluetooth enabled, so you download it and then it would record people you were in proximity with in the past. The trouble is that you need very high uptake. At least 50% of the population needs to have installed this, preferably 80% or more. And that isn't the case. You just can't achieve that. Not everyone has a smartphone. Not everyone has this thing turned on. Also, different smartphones, the performance of Bluetooth is hugely variable. So it's not actually a very uniform way of, it's not a very effective base. Whereas with something like a smart card, and Singapore is now giving up on its app and switching over to the device-based approach. You have this device and you give it to everyone, and everyone walks around with this thing a bit like a credit card, and it keeps a record of your last month of contacts, and you can build in really very impressive privacy protection to the system. And so if you become a case and you activate a code, it then tells all the people who you've had contact with certain parameters that they've been in contact with a case and they should self-isolate right away and get tested. And it can also potentially do the second generation as well. So the contacts are the contacts. So I think this really could be technically it looks very promising.
Great. I'm just going to ask two final questions together. So Richard Simpson has asked about different types of masks. So we've got the N95, FFP2, 3 masks, new or out of date, and also a variety of face coverings. So given the research you've been doing on masks, if you were to really try and implement that much more seriously, what specifically would you be advising to the public in terms of what they should be using?
Well, I think the public should be using non-medical masks. These are reusable fabric masks. I was interested that the World Health Organization, they've changed their guidelines completely, and they have quite detailed specifications for the kind of masks they think the public should be wearing. It's interesting in Hong Kong and I think a number of other Asian countries, they've actually issued masks to the entire population. And I think this is obviously partly to deal with equity issues, but also to avoid waste, because some of these masks they're giving out can be, some of them are good for 50 or 100 washes. So you can use the same mask for months. You might have 2 of them and alternate them. But I think it's far preferable to surgical masks or N95 masks, which is obviously creates a huge waste. And N95 anyway, I think they're very uncomfortable for most people to wear for long.
Yeah, absolutely. We need to think about what's sustainable and appropriate for the population. Well, we've still got lots of really interesting questions I'm not going to be able to get through. Apologies, colleagues. I can see other points here. If there's anything key, do let us know and we'll email those to Michael. So I'm going to say a few words about our future webinars now, but I just wanted to thank Michael sincerely again for what was a really outstanding presentation and some valuable information and insight that we, I'm sure, can all learn from. So in terms of the next few weeks, we've got 3 more planned, and then my intention is to pause for a few weeks. Not that any of us are necessarily going to be going on holiday anywhere interesting for very good reasons, but I think we will regroup and see what we can offer after mid-July. So for the next 3 weeks, hugely important issue next week, Naveed Sattar, who many of you in the UK will know from the University of Glasgow, who's going to be focusing on COVID-19 and obesity, what we know to date and don't know. And then following that, of course, the world's attention is now shifting to Latin America, the challenges they're facing. So I'm really delighted we have a speaker from both Brazil and Chile on the 26th of June. And then just on to the next slide, if you wouldn't mind. There we go. Thanks. Laura. Our one on the 3rd of July is from South Africa, which has been very interesting in terms of their response. So we'll have a colleague who's an epidemiologist talking about it from an infectious disease perspective, and then my colleague Charles Parry, who leads the addictions research in the South African Medical Research Council. He'll be commenting for a shorter periods at the end on what happened when they had a temporary ban on alcohol sales in South Africa. So I hope those will be interesting to you. Thank you very much again, everybody, for listening.